Hey, OncoPT, and welcome to this episode of the OncoPT podcast. In today's conversation, I'm speaking with Dr. Lori Boright, who is here to talk all about palliative care and what it means within oncology physical therapy, and perhaps maybe how oncology physical therapy should and can be a bigger part of palliative care even earlier than what we're utilizing it now. So, without further ado, let's introduce our special guest today, Dr. Lori Boright. Welcome to the OncoPT podcast.
Thank you so much, Elise. I'm pleased to be here. Um, I'll give you just a little bit of background about myself. I am about a 10-year practitioner in the field of oncology rehab. I didn't start as an oncology rehab clinician. Really, it was talked about very little in my formal education and my training. I came to the practice area by accident and some personal experiences that drove me to that. So I can speak to that a little bit later. Currently, I work at Oakland University in Rochester, Michigan, not Oakland, California. A lot of people get that confused. Sometimes I wish it was California, but I really love the Four Seasons, and we're getting towards the most beautiful time of the year in Michigan, fall. So it's great. I teach some in the entry level DPT program, but the other thing that is very notable for this conversation is my role coordinating the graduate certificate in oncology rehab. So it's a post-professional program with a global student body, and it's a really wonderful program to prepare working professionals, not only for board certification, but also just to be leaders and program developers in the realm of oncology rehab. A lot of my research really is prevention related, and oddly enough, prevention I really do feel like has a role in palliative care. So we'll talk about that a little bit too, as one of my sort of soapbox and research platforms. So I currently have a couple of studies going with Ascension Southeast Michigan, and I'm also pretty heavily involved right now with the moving forward those recommendations for entry-level criteria. So Dr. Deb Doherty, my mentor, I cannot have a conversation on oncology rehab without mentioning that name. She and I have been working for 5-6 years, maybe even a little bit more than that now, and have developed a wonderful sort of modular packaged curriculum that we deliver to every physical therapy program in the state of Michigan. So we really are fortunate in that regard. So those are my passion projects outside of the context of the conversation that we'll have today.
If you're thinking that Lori sounds familiar on the podcast, it's because I have had her previously to talk about this amazing endeavor, little thing called the textbook that you and Deb and Chris were so integral in creating. So I feel like we would be remiss if we didn't call that to mind also.
For sure, for sure. Yeah. Wonderful pandemic project. That's kind of how I conceptualize it. We literally conceived of the idea 2019, but proposal process takes a while with publishing, and literally got the green light and the go ahead from Elsevier the week the world shut down in
Nice.
March of 2020. So yeah, that's the one thing I will say about that book. And I know we've talked about it before, but the contributors on that book were not only frontline workers, but they were major contributors to the exceptional work that resulted from that. So that collaborative effort.
Now, what we're talking about today, as I teased earlier in the episode, is really about palliative care. And I think we have to establish what is palliative care at the very beginning of the episode, because palliative care is really misunderstood. And I know, had I not grown up with nurses, the connotation of palliative care is very different. And it's one that I often have to work on with patients because, again, they also have that very misrepresented understanding of what palliative care is. So, Lori, what is palliative care, first of all?
So palliative care is the delivery of multidisciplinary services when there is the established diagnosis of a chronic illness towards the end of life stages, but where palliative care and hospice differ, and I think sometimes it's important to draw those distinctions, is that hospice services carry the requirement that someone have a lifespan of less than 6 months to live. So palliative
Mm-hmm.
care really, the requirement to have palliative care services is that someone has a chronic illness
Mm-hmm.
that is um, potentially life limiting, but certainly limiting their quality of life, their function. And both of those things, really, you cannot ignore that rehab services really have a hand in improving both of those things. So, as we will get into, it really does not make any sense to me. It makes my head spin why we are not first to the table. Certainly, we are moving in that direction, but that's our domain, is improving quality of life, improving function, and the end goal really is to provide a death with dignity, and that is the end goal of both hospice and palliative care services. But I would argue, again, I've teased, but rehab services really needs to be involved much earlier in the process. We've seen growth in palliative care service utilization over the last 2 decades, but really not an uptick in the amount of referrals to rehab services through that palliative care lens.
One of the things that I'm going to pick out that you said is that palliative care is really an all encompassing thing for someone who has a maybe life limiting condition, but more importantly, quality of life affecting condition, right? So, in this kind of visual that I'm painting in my head, palliative care is kind of like the umbrella that can that covers basically all of the cancer quote journey for our patients, right? From diagnosis to through treatment, beyond treatment, into long-term survivorship, end of life, whatever that looks like for that patient. But hospice is really under that umbrella. They are not the same. Palliative care overarching all of it, palliative care, or excuse me, hospice is kind of at that very end. And so it's really important, dear listener, that we are making this distinction, because a lot of this is going to guide the conversation and really just support why Lori and I are in such big agreement on why we need to be a part of the palliative care experience. And that needs to start at the very beginning, like at diagnosis. And I would say maybe even like a little before diagnosis, but maybe a different conversation for a different day.
Certainly. And I think it is important to recognize there is a lot of data that suggests the utilization of both palliative care and hospice services occurs at the very end of life. So oftentimes, and I think this exists outside of healthcare in general, just in our general community, there's a little bit of a stigma against hospice and palliative care related to this whole I'm giving up, right? So the doctor has recommended palliative care, or the doctor has recommended hospice, that means it's over. So
Right.
certainly I think there's a little bit more truth, when we're talking a hospice circumstance. So people are reluctant to, accept and begin to utilize those services. So I think conversations like this and normalizing it in the healthcare community, as well as broadening that to our general population, palliative care really does have a place across the continuum. There are statistics that say about 60% of adult Americans have some sort of chronic illness. And if they had some sort of surveillance of that chronic condition and, a fully operational palliative care team, which I believe includes an internal medicine physician, which, that's how that the majority of those referrals, at least in an ambulatory type of scenario, would initiate. I think, we can start to have these conversations in a little bit more of a normal way through that lens of quality of life enhancing, function enhancing, at a much earlier stage. And therefore, transition someone who does have a life limiting illness into hospice care, within those final months of life with dignity and, fully prepared for, and fortified. Prehab, as I mentioned, in terms of a preventative thing, is one of my, main areas of focus, not only for research, but as a professional passion. And I think preparing someone psychologically, physiologically, emotionally, spiritually for that end of life trajectory, and it extends beyond the patient too. I know I'm talking very globally now, but the family becomes a part of the conversation and the interventions in palliative care and hospice. So it's a family experience, and that extends beyond related family to caregivers and friends to really help just improve that overall end of life trajectory.
It's been really interesting watching. So there's a cancer clinic in my area, and like they've had palliative care. They have, I believe she's an internal medicine physician who is like the head of palliative care, and she would get some referrals while I was there, while I was a part of that environment. But it's been really interesting over the past few years since I've been gone. They've had a nurse practitioner come in, and I think they've done a little bit of rebranding. And I don't know if this is like the case, or this is actually how they've changed things, or if they've just kind of like casually changed things like informally. But they're now approaching it as more of the quality of life clinic. And even just that language, I think, activates a little differently in the brain as a non-brain scientist over here. And it has exploded. I mean, this nurse practitioner is traveling to a bunch of their different locations and is seeing a ton of patients. And I personally, that sounded very Southern there. I personally am really loving to see it, because patients are getting those services, but they're referring to rehab a lot earlier in the process. And so my patients aren't wandering around for like 6 to 8 years after their cancer diagnosis, finally now getting help. And again, we could talk all day about, do we need to have a change in like the language that we're using? That's outside the scope of this. But what I do want to come back to is, we've established palliative care, obviously huge for quality of life for our patients, and can really flow into some of those hospice end of life conversations. How does rehab and oncology physical therapy fit within the palliative care realm? Because some early research kind of showed how mind-blowing it was for other healthcare practitioners to think like, oh, rehab could be useful here.
I think, the answer to that question is it can also extend beyond palliative care into just the general overall realm of oncology rehab. We are not utilized to our capacity. You and I had some conversations leading up to this interview regarding, the really end goal is that every patient diagnosed with cancer receive a referral to rehab, right? And ideally to an oncology rehab trained clinician. We know that is not happening. I don't have statistics to rattle off at what level, but there are statistics that say, up to 89-90% of patients with a cancer diagnosis will have some sort of adverse effect that we as rehab clinicians can mitigate. And so when we talk about how this relates to the palliative care domain, as I mentioned previously, we've seen an uptick in utilization of services for other chronic diseases, stroke, COPD. Those are two prime examples of diagnoses that we would ordinarily see, through a palliative care service line.
Right.
So it is a relatively novel concept, and I'm really tired of saying that, but it is true. We have not achieved, that end goal of seeing every single person diagnosed with cancer. Ideally, this concept of prehabilitation, when we see someone at the time of diagnosis, we've established a relationship with this individual, right? And we watch them transition, and it's like that watchful waiting, prospective surveillance, when they need our services, because we know now, it's not if, it's when they will need our services. Those statistics really don't lie, right? For whatever adverse effect that we might need to manage throughout the trajectory, and it will change. We are all fluid. Every body is different, and how they respond to their cancer treatments and all of that. So I think, when we're talking about like sort of a nuclear hospital type setting, it makes sense. And I think I can't speak statistically, but I think it happens a little bit more naturally when the physical therapists are functioning and following the patients on the oncology floor. When these conversations arise around utilization of palliative care services, we're already part of that integral team, right? So those conversations happen very naturally. So my assumption is that we are, definitely much more involved throughout the process there. If someone doesn't have an acute hospitalization and their utilization of services are primarily ambulatory, you're sort of at the mercy of your care team picking up on issues that might be mitigated from a palliative care referral and working with the individuals of that palliative care team. Did I blow your mind there?
Oh my God. I like full body chills. Whoa. Yes. Keep going.
So I do say that, and I say this often, I feel very fortunate to be a healthcare practitioner and certainly in this domain because I know how to advocate now, right? As I mentioned earlier, my entry into this area of specialty practice was not by choice. It was by circumstance. Both of my parents, who are, different types of cancer survivors to this day, did not receive any kind of rehab throughout any of their cancer, their respective cancer journeys. So, that was the light switch moment for me and why I felt the need to make it different for other individuals. So I think the same exists here. It isn't until maybe you have a personal experience that you realize that this could be a very different thing. And so again, I feel fortunate that I have the knowing to advocate for these things. And I think, again, the more we make these conversations normal in the healthcare community, as well as outside of the healthcare community, it's a large, a very ambitious goal. But it's that whole adage, when you know better, you do better, right? If I know that when my family member starts to decline and we're moving towards the end of, it's a non-curative thing, but they're struggling in certain ways, I will ask the question. I will advocate for my family member or myself if it happens to, if that individual, is in that position. I will advocate for myself for these services because it isn't always about, everybody having this broad lens. You would think that, in this day and age, when you are integrating with a palliative care team, that everybody would be conscious of what everyone else is doing, but that really isn't the case. And it's not a judgment towards the other members of this team. I sound very passionate about this because I am. Our colleagues on these teams are really focused and siloed towards, their area of practice. So physicians, I say this a lot when I'm doing my entry-level stuff with the entry-level DPTs. All of these life-saving measures, chemotherapy, radiation, oncologic surgery, those physicians are in the business of saving lives. We are in the business of enhancing them. So we have to invite ourselves to the table. We have to follow our patients through the trajectory. If your orthopedic patient ends up with a cancer diagnosis, I take it on myself. I'm here for you for these things in the future. So it comes from us as well as just being a really responsible healthcare practitioner to make sure that our patients and our communities know the services we provide, the things that we can do to enhance quality of life throughout that survivorship trajectory, and certainly within the context of the life-limiting end of things, improving that quality of life and helping just improve, whatever functional limitations might exist.
You've already had one mic drop moment of this interview. I'm anticipating more just based on how fast that already hit me. But the patient being at the whim of someone looking out for a specific impairment purposely, accidentally, and then getting the referral to rehab is, I've never heard it said like that, but it encompasses so much of the experience of what often happens, I think, in my experience when it comes to oncology and making that connection for the patient into rehab for this. And this ties in obviously really well with our conversation about palliative care, because I think unless you are in a system, outpatient, inpatient, whatever that is, where there are certain things, conditions, experiences for the patient that trigger an automatic referral, or if you have a practitioner, again, maybe that's an oncologist, a physician, an NP, a PA, a nurse, somebody who is picking up on this information to then say, you know what, you're really going to benefit from rehab. Like, it's very much, we're dependent on those two things for the patient to actually get connected, when we know that we could, again, intervene so much more quickly. We could see potentially faster progress. Maybe that patient isn't going to see as much decline, if they're able to get into those services. It's just mind-blowing that it's such a chance encounter for so many patients to actually get in and get these services. And it shouldn't be, but it is.
Agreed. And I think that's another argument for the need for a rehab referral at the point of diagnosis. And I think of prehab, right? I know that there are so many arguments against prehab, or, challenges. I guess that's the better way to conceptualize it. Because it's not that people don't want to do that. There's just challenges, right? There's appointment fatigue. There's financial reasons why someone might not want to begin to use their rehab benefits prior to a cancer diagnosis. All of that is very real. But I think that it is so important to discuss in this context, because I think of it as planting seeds, right? So this is not a discussion on prehab, but when we do prehabilitative rehab for the cancer population, we are providing education at a minimum, and then, prescriptive exercises where that is required. But some of this education, I'll go back to that, is I am here for you when you need me. And so that, again, will be my, my sticking point for this part of the conversation, because we've already talked. It's not if, it's when they will need us. And so, again, there's a lot of information coming at the patient at this point. Involvement of the family is paramount, but you can already sort of paint that picture of this is a cancer continuum, and it shouldn't all rest on the rehab clinician. Again, a fully functioning interdisciplinary team, even as part of this prehabilitative process, can explain some of this stuff. And having these conversations, making it normal and not scary, and maybe not even talking about death at this point, because that's not part of the equation. But this concept of palliative care, and how you said it's a quality of life clinic, health and wellness. Why can't we talk about it in the context of health and wellness? We want to keep you healthy and well. And these are the strategies that we would like to employ. And these are the services that will be available to you, and inclusive of a, referral and, involvement in our oncology rehabilitative programs. So I love what you said, and I wanted to go back there because there is a lot of emphasis in recent years about health and wellness. Our population, thankfully in the United States, we're starting to get there. Our healthcare delivery model is a little bit of a lag behind in terms of it's much more reactionary, right? We need to move towards this prevention standpoint. And I am so pleased that even our national association is in really embracing the idea of how important we are as rehab clinicians in the domain of prevention. So I think in that context, sort of using that momentum and normalizing these conversations towards health and wellness and utilization of services when they're appropriate.
It makes me think back to when I first started working, and prehab was a big push. Prehab is obviously still important. That hasn't gone away, right? But I'm thinking about when I was referred patients for a true prehab visit. It was before treatment started, after diagnosis, and just considering even like probably how poorly I was doing, how poorly I was approaching this, and maybe how I would change it now for patients, knowing what I do about palliative care and kind of all this. It makes me think of Perhaps if I had approached, and perhaps if we approach prehab visits less as a let me tell you all of the different impairments you could likely face as a result of this cancer diagnosis. Important information, but maybe I don't need to lead with that. Maybe instead approaching it from more of a, like you mentioned, Lori, my job is to try and keep you as healthy and well and mobile during your cancer treatment as possible. Maybe that is something internally, as again, you and I are the rehab clinicians. Maybe this is something that we start when we do see that patient. We initiate that process. And maybe that is this is how we can get more buy in with the patients we have now, and then again have a different strategy for how do we actually get more patients connected to us. But I think that could be a really good strategy. What are your thoughts on that, Lori?
I would agree completely. And I think, patient education is paramount. And again, bringing in whoever supports the patient throughout, their survivorship journey is important to involve in that conversation as well. And I think having the transparency about, the impairments, yes, you mentioned, and I don't know that we need to belabor that, but spinning it, right, the conversation towards, we want to keep you healthy and well, and this is, our commitment to you. There are many things that you might experience, but we need to have that open dialogue about what you're experiencing, and when you're experiencing it, they might not be in your care, when they start to experience those things. So having the knowledge and really feeling empowered to verbalize those things, that this isn't a normal experience. I mean, it might be a normal cancer experience, but it doesn't have to be a normal life experience, right? And so using that terminology too, that yes, it's common to have nausea and, feel weak and fatigued when you are undergoing chemotherapy. However, that doesn't have to be your reality if, we can intervene and get you the proper even medications outside of our scope. But help. And so, again, these palliative care types of concepts do exist in other domains and are utilized, right? Because I think that physicians are good at doing that. One of the other things I guess I want to interject here is that I feel like we also, even the general concept of oncology rehab, we have a lot of educating to do still to our colleagues in general medicine and oncologic medicine, mid-level providership, all of those areas. And I think we also need to have those conversations and provide that education related to what we can do in palliative care. Some of what I believe is, resistance to refer to a rehab clinician during a palliative care circumstance revolves around this whole, well, you guys work patients really hard. And so there's that mindset that maybe we would be detrimental. And so I think providing that education related to, we tailor our treatments and interventions to what the patient's needs are, right? And so there's different care models that exist, this rehabilitation light, meaning that we would tailor, a rehab intervention to what the needs are at the time. If the patient is having significant fatigue or, just a really off day where we wouldn't want to, exercise someone to their, perceived moderate intensity. There's other things that we can do, right? So we can work on pacing and education and, family training. So I think providing that it isn't always about that we're going to be exercising at moderate intensity so we can get this 150 minutes a week, right, of moderate intensity per the ACSM. This is like what they do. Not necessarily. We are a doctorate level profession now and can make these determinations, right? We have that towards our credentials. So I just want to be comprehensive in terms of additional care models. So case management would mean that, we're really maybe not proximally involved, but managing, equipment needs or, monitoring of the exercise program, if they're doing a home exercise program at that point, I've done a lot personally of this rehab in reverse, right? In an acute care situation, maybe the goal of the patient is to go home from the hospital, and they might not need a walker at that point, right? Because they're doing relatively okay, but the prognosis is such that maybe they will, continue to weaken. We use that time and energy towards training the patient in using a walker before they need it, right?
Yeah.
And to that end, training the family to help the patient with transfers and ambulation, also ahead of when it might be needed. We can also function really well in a supportive care role, meaning we're working again on educating the family, providing equipment that might be needed in the home setting so that the patient has what they need. A significant majority of the patients that I have worked with that has been a goal. Right? So they want to leave the hospital. They want to be at home, spending time with their family. There's, other things that might be related to that. I want to be able to interact with my grandkids over this whole pandemonium. That's what I call it, the pandemonium of 2020 to whenever. Babies couldn't come to the hospital, but if they have a grandchild that they want to hold, they want to go home so they can interact with these individuals that those experiences had been limited. And then, just kind of rounding out this conversation, the palliative prehab concept of I'm going to tell you what you need to know before you need to know it. I'm going to fortify you since we can work with you now, at that moderate intensity level or whatever, they can tolerate. I'm going to get you as healthy, physiologically as I can. Utilization of the rest of the care team to help with spiritual needs, to help with their social needs, and maybe bringing some of the family together. There might be, strain and issues there, and again, outside of our domain, but making sure that they're getting full utilization of that team to fortify them in all domains, I think is so important.
Totally. You mentioned something, and you've kind of sprinkled it in throughout our conversation today. But off air, you were talking about prevention as a special interest of yours within palliative care. And originally, when I first hear that, my gut reaction is those are complete opposites. Like, what are you talking about? But hearing you discuss more of like how the prevention we do in palliative care is so much bigger picture than what we thought, or like what I thought originally. Can we talk a little bit more about what that prevention means within a palliative care scope, and then how that translates to potentially the rest of that person's life?
Certainly. And I think using those care models really does kind of tee up that concept,
Mm-hmm.
whole prehabilitation or palliative care prehabilitation. Really, prehab is secondary prevention, right? We want to prevent any potential adverse effects from occurring. And if we can't do that, then we intervene on that tertiary level, right? That's where our profession really does a supreme job, because that's literally historically where, somebody has a problem and we help to fix it. But we want to stop those problems from actually happening. So when I conceptualize palliative care prehabilitation, it's sort of like a tongue twister. I have to visualize it in my head and then say it. Palliative care prehabilitation. I think of fortifying the physiologic reserves so that we see less of a functional decline. So, you can look up, there's wonderful studies, and really, this isn't a plug for the textbook, but there's a great visual image of this in the textbook where we have a baseline level of function. And if we can raise that baseline level of function before they actually need palliative care services, that decline is slower, and that curve is, there's much more area under the curve, which I see as, quality of life sort of. If we don't raise that baseline, then, theoretically, quality of life is less diminished. So when I think about that, it's really, it makes perfect sense to me why we wouldn't want to do that. Certainly there are going to be limitations, and we're practicing prevention all the time. It just kind of depends. Are we doing primordial? Are we doing primary, secondary, tertiary? Even quaternary, I think, is another good way and actually appropriate way to kind of interject in the concept of palliative care, because oftentimes there is over medicalization, right? Patients are getting too much. So conceptualizing where we are in the scope of their needs, and providing just what is appropriate. So I think that whole concept of surveillance and making sure that there's open communication, that the patients are, free to express their concerns, needs related to quality of life and function. It's imperative that be at the forefront of, and why when I conceptualize an interdisciplinary team, really the patient is at the center of all of it.
Yes. Yes. And again, hearing you say all of that and tie it all together, Lori, makes perfect sense. And I think it's interesting that you say you're already practicing this, right? Like, as a physical therapist on the rehab team working with this patient population, a lot of times, whether consciously or subconsciously, we are working to try and build them up physically as much as possible in preparation for what we know is coming. And if that's not prevention, like, I don't know what is at that point. So it makes a lot more sense when you like really tie it in that way.
Yes. And truthfully, you gave me chills right there. I agree completely, wholeheartedly. Yes. So see, we can both have that effect on each other. That's
Oh my
great.
God. I love it. This is why minds have to come together, y'all. Like, this is what's the best part of this podcast is when I learn from other people like this. Oh my God. All right. So, burning question that I know the listener has right now. They're like, Lori and Elise, this sounds great. I'm on board. Like, I'm hooked. How can I actually make this happen in my practice? How can I actually advocate for a greater inclusion of physical therapy in the palliative care capacity within my institution? Not just like I need to be a part of this, but I need to be a part of this earlier. So, like solve world hunger basically is what I'm saying.
No easy
Quick
task,
method.
right? So, I do have quite a lot of experience in terms of building programs, and I have another um, just amazing mentor who is like screaming in the back of my head. We don't wait to be asked to do things. We invite ourselves. We know that we have a place at this table, and we find out when these interdisciplinary team meetings are happening. We find out who the key players are that either manage these meetings or you know dole out the tasks for the day. We need those people to know, and that's where it's on us to educate too. We find these things out, we provide the education in terms of what we can provide and how we will really have a positive effect on the patient experience. And and it's even being involved with some of these hospital administrators and healthcare administrators who might say, we can't afford to have another person involved and take you offline from productivity. That's where we need to be prepared with some data, right? And being able to speak that language too. So it is no small task. Having a supportive leadership team is really paramount. The other really big thing is a physician champion. Physiatry, if you have a good oncologic surgeon who values what who sees your work and what you're doing, use those connections as buy-in and as ways to get in to these committee meetings, to really push forward what our goals and objectives are and how we can really improve the patient experience. So, the solving world hunger and solving this problem, really huge problems that one person alone can't do. But I really feel like, again, the growth of this specialty area of practice in our profession, and the people involved, our pioneers, again, have done a really phenomenal job. But we have to carry that torch now. We have to move things forward and really continue to be in the faces of these individuals who can create change. And that includes us. We are creating change when we do it, but you need to find those people who can make things happen, and be on that team, because you will make things happen too.
Oh my God. I just love this so much. So, anything you would like to leave the listeners with today, Lori, before we sign off?
I really just would commend those who are moving into this area, even if this is just, availing yourself of some, peripheral information. If you don't have a fully functioning, oncology rehab program at your institution, maybe you want to build one. Maybe you're an orthopedic therapist who realizes the value of availing yourself of some of these concepts to better serve your population. I really do just commend you. Those of you who are dipping your toe in, I would invite you to jump in, because this community is really a wonderful and supportive community. I will fully say my career took off when I moved into this domain. And I feel like I'm doing my best work. It isn't a job anymore, it's a vocation. I really wholeheartedly believe that. And I feel like the community, and this is my plug for, just doing the cannonball and come straight in. The community is supportive. We are really pumping out resources at this point. So there is no excuse for I don't have access to information. There certainly is a dearth of information that we can't, hide behind. But we need to contribute to, growing the evidence as well. But we're pumping it out, and we need more clinicians, because that's just one last thing. We have more of a population than we can possibly serve. So that is one argument. I don't want to leave it on an argumentative status, but that is one argument. Can you really, serve all of our patients? If you're asking to see all of our patients, can you really serve them all? No, we absolutely cannot. And so that is my plug for, we need more oncology rehab trained clinicians. So come aboard.
When I first started just a few years ago, there was this statistic that was put out, Lori, and I'm sure you've heard of this, but they talked about in the year 2025 that we were expecting 50% of Americans to be diagnosed with a cancer at some point in their lifetime. And back then, like, again, thinking baby Elise, first years of practice, that was like, oh my God, that's so far away. It is about 16 months away at this point. Like, we are living in the future that, again, I only imagined previously. And this countdown, it feels very ominous in my mind, but it also is just a further spark to really lean into this and making sure that everybody has access to this level of care and services. So again, Lori, thank you so much for coming on the podcast. Would you mind sharing where my listeners can follow and connect with you on the internet?
Of course. I have a LinkedIn profile, Lori Boright, and my Twitter profile is at Boright Lori. So just the reverse of that. So yeah, I would love it. Lots of great things are happening on those platforms, oncology rehab related.
And again, going back to your point, I have never been anything but supported when I connect with other oncology junkies or oncology mafia members. Like, I don't, like, there's so many names out there, but I've never felt anything but supported when I interact online with these individuals. And I'm really, really excited that someone who's hopefully listening and is going to jump in with us, because we're really excited. We're here and we're going to catch you, and we're going to make sure that you have what you need. So Lori, again, thank you so much. I will, of course, link all of Lori's information that she shared on the show notes today, as well as where you can get your hands on a copy of the amazing textbook that we teased previously. So make sure to check it out. And again, this is Elise with the OncoPT. And remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.